Hello, and thank you for joining the Rosewood Institute's clinical lecture series. And today I'm delighted to present Lee Neagle, Program Director of the Rosewood Centers for Eating Disorders, as he presents Help Me Go Away, Treating the Difficult Adolescent. And my name is Libby Neal. I'm Executive Clinical Director of Education and Training. And we will have a question and answer session at the end of this. And if you have any questions or you want a copy of the slides, please do contact me. You'll see my email address on the last slide of this presentation. So on that note, I will turn it over to Lee. Thank you, Lee.
Thank you very much, Libby, and welcome everybody that's part of this webinar. Thank you for joining me in this. Again, if there are any questions, we'll try to answer as many as we can at the end. If there are any that go left unanswered, please do contact Libby. She's very good at getting a hold of people and to answering those questions. So moving forward, we're going to be doing our second kind of in the series of adolescent treatment, and this one we're going to be talking about treating the difficult adolescent. As we look through here, I'm going to get us into the goals of the presentation, and I really want us to come away with understanding resistance, how we can work with it, understanding and normalizing adolescent behaviors, how to find balance in education of eating disorder and consequences of continued practice, recognizing milestones of recovery, even when there might be resistance or there might be adolescents pushing you away, building rapport with the adolescent that's engaged in maladaptive behaviors, and whether or not to keep the family or having them remain involved in the process. So we're going to go right through the first slide. This is a little offshoot of the previous webinar, and I talked a little bit about adolescent development, specifically how it's kind of been seen through the eyes of different clinicians over the years. In the last webinar, I did talk about Erickson and a lot of the identity versus role confusion, which is inherently the adolescents trying to find their own way, pushing against previous ideals or previous norms, trying to answer the question of who am I and what's important to me. Piaget also describes this adolescent stage, this 11 to 12 up into adulthood, the formal operational stage. And what he described is the adolescent being able to develop more abstract thought and problem solving. As their cognition starts to change, they start to look through things more scientifically, and they are able to understand more and have greater depth of understanding. And I think that's important to know when we're working with adolescents, is they aren't not children, because they are thinking differently. Eklund also talked about egocentrism with adolescents, and he talked about two specific things that I really like to talk about. And if there's any clinicians out there that have worked with adolescents, they can probably relate to this. The first thing he talked about was an imaginary audience, where adolescents now believing or becoming more self-aware of their surroundings, that I'm being focused on. I'm the center of attention. Everybody's paying attention to what I do and how I behave and what I look like. And again, with adolescents, I've worked in facilities where I've had one adolescent tell me, well, it's hard to eat my meal because everybody's staring at me and they're all watching what I eat. And then I have an adolescent that's in that same group tell me, well, it's hard for me to eat my meal because everybody's watching me eat, completely separate of each other. So you can imagine 10 people thinking the other 9 are looking at them only, and it kind of gives you the concept of the imaginary audience. They also talk about personal fable, and this is a hallmark of not just adolescent treatment, but adolescent development, is that my experience or the adolescent's experiences are completely unique, and no one could possibly understand what that adolescent is going through. We see that when adolescents grow up and talk to their parents and say things like, well, you don't know what it's like to be a kid, you don't know what it's like to be a teenager, you don't know what I'm going through. And they kind of have that disconnect of the fact that their parents were also teenagers one time and were also going through a lot of these same developmental stages. So I think it's important to remember these two specifically for treatment, because it really plays itself out in eating disorder treatment. The idea that I'm so separate and unique that nobody could possibly understand me. And this, for example, can play out with adolescents that are trying to justify continuing their eating disorder behavior with a dietitian. Say, and we hear this a lot as well, well, my body doesn't need that. I know other people might need that, but my body is different. I'm completely unique. It's different for me. You don't understand. So just remember that when we work with these are two concepts of working with adolescents and treatment that I think are really important. The next slide, and I guess this is kind of the crux of this webinar, and I want you to understand that resistance is healthy and resistance is a natural part of recovery. Now, it should be expected. When going into treatment, when working with adolescents, we should expect some resistance. Now, it can come in two forms, one being what we would call overt resistance, which is, I'm not going to do it, you can't make me, or covert resistance, which is, I'm going to tell you yes, and I'm going to do everything you ask me to do, except when you're not around, I'm not going to do that. Again, that can come up with adolescents and eating disorder specific treatment when that adolescent is presented as very polished, that they're perfect, they're this perfect client, that they're insightful, and that they're doing all the work, and they're compliant, and they don't make waves, and they don't get angry. But then all of a sudden we notice they're not restoring nutritionally. Well, what's happening here? We confront on it, and they say, no, I'm doing everything I need to do, until you find out later that they've been somehow exercising in the room or compensating in some other way, but they're doing it very secretly. Typically, meeting resistance with resistance is really futile. This is kind of force on force. It doesn't really work, I don't think, with adolescents, because if you've ever tried to meet an adolescent with resistance, you've probably noticed that they've dug in deeper and held on more. The example I always like to use, and it was an example that was given to me by one of my clients some years ago, that they had chores, and one of their chores was to take out the trash, and they were going to take out the trash, and then before they got there, Mom said, oh, can you remember to take out the trash? And the adolescent went, well, I was going to until you asked me to, and now I'm not going to. And that kind of encapsulates some of the work that we do with adolescents, is that if you take a forceful approach or a very authoritarian approach, don't include them in the process, tell them that they're wrong, tell them that their thinking is distorted, tell them they don't know what they're talking about, and you're going to find an adolescent that's going to shut down or become more overtly resistant or more covertly resistant. So it's important to not try to meet resistance with resistance. I think that also for providers and family members and loved ones, I think trying to meet resistance with resistance can also burn you out very quickly as you try to get this adolescent to do something you think they should do, and they're not doing it, and you get frustrated, and there's anger, or there's resentment, or there's passive-aggressive communication. I think all those things lead to a disconnect and not a bringing together of the adolescent and the family and support team against the eating disorder, against the substance abuse, against the self-harm. So I think it's really important to learn to embrace resistance. It's really a paramount, I can't think of any other descriptors, hallmark to treating adolescents. You need to embrace this part of treatment. So I also want to talk about the importance of group therapy. A lot of the work that we do with adolescents, I tend to find to be very successful in groups with other peers that are of similar age and so similar developmental stages, because I really truly believe that adolescents do learn from their peers. If we go back to the first couple slides that we talked about, we know that there's a pushing away against authority figures. There is an acceptance or more of a desire to be accepted from a peer group. That becomes very important. So if you can get an adolescent group that's working a treatment program and somebody that can call out another adolescent, calling another adolescent out for their behaviors, what we call helping them be accountable, or the adolescent learning to communicate to other adolescents in an effective manner and helping hold other people accountable, I think that becomes a very powerful tool in the change process. A lot of times if you sit in a group, and if you have done groups with adolescents, you may have seen this where an adolescent may be in denial and saying, well, cutting my apple up into 70 pieces, that's not an eating disorder, I've always done that. And then they hear another adolescent go, actually, I think it is an eating disorder because I did the same thing and I had the same resistance and I pushed away from doing any work on it until I finally came around to doing it and realized how much anxiety it caused me, how much struggle I had with it, that I knew it was something deeper. Then you see the adolescent's eyeballs kind of pop a little bit, and that realization that nobody understands me is kind of put by the wayside if you can create that group. And that might be the agent that leads that adolescent from going from pre-contemplation to contemplation. I think the peers are very, very powerful, and I think it's just important for us as clinicians and providers that when we are part of a group, we are modeling healthy behavior, but we're also encouraging an open environment so this communication can happen. Adolescents in a group therapy can also learn about their relational styles, but also we as providers and clinicians can see their relational styles. We can see how they communicate. We can see kind of where the difficulty lies, and then we can help change that behavior just by understanding more so how adolescents, this specific adolescent or your adolescent, functions. Group members can also practice new skills. They can also process any problems that they're having, difficulties with rigidity, perfectionism, black or white, all or nothing thinking, generalization are just a couple things that really can be presented during a group process. Also, we'll be talking about techniques of motivational interviewing, acceptance and commitment therapy, and cognitive behavioral therapy. So these are some tips that I give out there, and I found that these were helpful for me, and they've been passed along to me from other practitioners in the field, is that when working with adolescents, I think, number one, it's important to ask questions, especially open-ended questions. We really shouldn't have an agenda in the sense of we're trying to lead them to a certain answer. Allow the adolescent to speak and to be part of the process, and I think it gives us a deeper understanding of what that adolescent is going through. And it might be kind of shocking because some of the adolescents we work with might not be used to being allowed to be open, being allowed to talk. Maybe they're used to being talked at instead of talked with, and they haven't ever really been able to contribute. But I think breaking down some of that resistance is letting them participate in the process. And the second bullet is to really be consistent, which I describe as show up. If you're a clinician, show up to work every day. Present the same message daily. I think this is an important thing that I've really used in my treatment with adolescents is the saying, we will support every decision you make in life and wellness, and we refuse to enable any behaviors that lead to sickness and death. And I think if you can constantly present that message of we're willing to work with you, I just can't abide by or enable an eating disorder behavior or self-harm or the substance use. And if we can continue to process that, I think that gives the adolescent some structure. I think that gives the adolescent some consistency so they know where they stand. It's also really important, and I know this could be rehashing stuff that has been talked about a lot, is be empathetic during this process. It's difficult. It's a difficult process for an adolescent sometimes if it's residential or inpatient treatment to be far away from home, and to also be in an environment where people are kind of asking them to examine behaviors that they've used to kind of to feel worthy, to feel like I'm important, and we're asking them to kind of give that up or look at giving that up. It can be really difficult. The last thing is be human. Know when you're wrong. We are, should be, the models of healthy behavior and communication. We should be the models of healthy eating behaviors. If you eat with your clients, and if you're engaging in disordered eating or tearing things up or doing different combinations or something like that or restricting, it's going to send a message to the adolescent that this is normalized. And we really want to model those healthy behaviors and communication. So we are going to move to motivational interviewing, and this is kind of part of our interventions and best practices. I really find that motivational interviewing is really important for the treatment of adolescents because of the stance it takes when working with the client, which is really exploring their ambivalence and really working together towards change. The clinician or the provider in motivational interviewing is really presenting in a non-judgmental way and is really taking a side seat, so to speak, to bring that adolescent in to work together instead of working against or demanding or drawing lines in the sand. It's really about taking this non-judgmental approach, which I find is very effective in reducing resistance and increasing trust with the clients. Some of the interventions that you can use in motivational interviewing are a pros versus cons list. It really asks them and let them know, I'm not seeking an answer here. I want to know what are the benefits of your binge purge behaviors. I want to know what are some of the cons of your binge purge behaviors, and to really present that as I'm open to hearing all of this stuff, because then we can examine it. The use of timelines I talk about. Would you please write me a timeline for the next 6 months of your life if you didn't change any behaviors? Where would you be in 6 months? Or if you decided to change some of these behaviors, what do you think it would look 6 months from now? And then you can process that. It's also about setting goals. One of the hallmarks of motivational interviewing is really sitting down and identifying what are some of the goals that the people you're working with have. So if I have an older adolescent and she says, well, my goal is I really want to be a mom. I think that's really important to me. I really value family. I want to be a mother. And then what you look at is taking now, let's say, the restricting behavior. And we'll say, okay, how does a restricting behavior help you get to your goal of being a mom? And how could it possibly be hindering that goal to being a mom? And then hopefully the adolescent starts to kind of look at that and go, well, yeah, if my body's not healthy, I can't support another life. That's really difficult. Maybe my eating disorder is not giving me what I want because I do want to be a mom. And there, right there, that can be just change talk. Even if they just start thinking about it, like, oh, yeah, that doesn't really help me. That's important. We should be validating that and really praising that kind of change talk and that examination of what's healthy for them. Cognitive behavioral therapy also I know is very popular, and I know that a majority of people probably are very aware of what it is. I just want to make sure that I kind of put it in here. The cognitive behavioral therapy is, ACT, that's part of cognitive behavioral therapy. Motivational interviewing has large parts of cognitive behavioral therapy. And the one thing I want to talk about here is probability overestimation, because typically adolescents, especially if they're rigid thinkers, black and white thinkers, all or nothing thinkers, really overestimate the likelihood of a scenario occurring. So we might discuss fears, like what are some of your fears? And one adolescent I worked with said, gaining a pant size, I'm really scared of that. I'm very fearful of that. So we examined the fear and where that was coming from. And eventually we got to a point where I fear that I'm going to be alone. If I gain a pant size, I will be alone. No one will love me. And that's what, after we worked through, that's what we got to is the core fear. So what we started to do is ask her, how much do you think that would actually, like what's the likelihood of that occurring? She said 75%. So we said, okay, let's look at it then. Give me the evidence that you have that supports that statement, that if you change pant sizes, you will be alone and no one will love you. She came up with different evidence, one being, I've seen people on TV, I've seen people on the weight loss shows, they seem to be happier, they have more people around them than they do when they were bigger. So okay, we take that piece of evidence and go, so is it really true that because you saw this on these TV shows that it really means if you gain or change a pant size, no one will love you? And eventually she did get to a point that go, no, that doesn't really make sense because I've seen other people that are actually healthy and not in eating disorders, and people love and care about them, and they're accepted. So that's just starting to punch holes in some of the rigidity or the black and white thinking, and that usually, I think, is more effective once the adolescent, if they're severely malnourished, need to restore a little bit to be able to start cognitively thinking this way. ACT is acceptance and commitment therapy. Really the goal here is to help clients choose to act in effective ways even during difficult times. I put in here disruptive cognitions or psychological events. It really comes down to the adolescent being able to see I'm allowed to have my feelings and I can still behave in a way that's recovery focused. And an example I'll give here is somebody can say I look healthy, and that might be a trigger for me. I might think that I'm fat and disgusting and nasty and ugly and feel a lot of shame and a lot of anger around it, and I'm still going to go to my next snack and make sure I do it. It's really about empowerment and empowering the individual that they can still feel and behave in a way that helps them. Just like anger. Because I'm angry, it doesn't mean I have to punch a hole in the wall. But a lot of people we work with, when they have that feeling, it becomes so overwhelming and so consuming that they have to react to it. So part of ACT is helping them not have to react in that moment and still take care of themselves. It's also about values. ACT really examines some of the values you have. And again, identifying what the patient or client values, and then let's examine the behaviors and if they're consistent with what the adolescent is reporting for their values. And again, it's including them in this process. It's helping them. It's letting them be an active part of the recovery process. The next slide is stages of change. And I know a lot of people have probably seen these stages, so I'll go through them quickly as it pertains to eating disorders. A majority of the people that we see coming into inpatient or residential treatment are going to fall into the pre-contemplation stage. Pre-contemplation being, I don't have a problem, you have a problem, there's nothing wrong with me. It's kind of complete denial. I'm not even thinking about changing because I don't think there's anything wrong. Contemplation is kind of when that adolescent first kind of goes, okay, you might be right. There might be something going on here. Maybe this exercising until I pass out isn't good for me, but I don't know if I want to change it. I'm not sure that the benefits of changing my behaviors outweigh what I perceive as the negatives of changing these behaviors. So they're kind of in that, yeah, I understand, but I'm not really sure I want to do anything differently. Determination now is when those adolescents can move into that, yep, okay, I agree. There's something wrong here, and I think something needs to be done differently. But they're still not actively doing anything differently. They might be planning. You might hear people say, okay, well, I'm going to stop this behavior tomorrow, or I'm going to stop it at the end of the month, or I'm going to stop it after the holidays, but it never happens. If somebody's coming into treatment, you might see them in the determination phase of saying, yes, okay, I understand I need treatment. Let me research. Let me call all the facilities. Let me talk to the intake people at those facilities. Let me take notes on it. But I actually haven't changed those behaviors. When we finally move into action is when we're actively doing things differently. We're challenging our thoughts. We're engaging in different behaviors. If somebody is restricting, instead of restricting now, they're following a meal plan. That can be an action stage. If they're very critical of themselves and giving themselves very negative self-talk, maybe they're engaging in doing 50 positive affirmations a day. That's actions. They're starting to actively start to try to change these feelings, or I'm sorry, these thoughts, these behaviors, okay? As they continue to do that and can solidify in that change process, they can move into maintenance, which just is to maintain the changes they made in the action stage. But what happens if we're not cognizant or aware, especially with eating disorders, because of the long-term effects eating disorders have, if we don't keep a vigilant maintenance protocol in place, we can run into the problem of people relapsing. And this could be a situation where I say, or a client I work with says, you know what, I didn't do my snack last night. I've done everything else. I followed my meal plan for 3 months. I didn't feel hungry. I didn't think I needed it. So I didn't have it. And I don't think that there's a problem with it. Now, if we see a pattern of those behaviors, we're going to be moving into relapse, okay? And that can start the cycle over again into pre-contemplation. I also want you guys to know before I go off the slide that we can go through any of these changes throughout 10 minutes. One example I give is I've seen plenty of adolescents that I've worked with were really motivated. They said, Lee, we're going to change. I'm going to do my meal plan. I'm ready to go. I don't want this eating disorder anymore. I have my motivational cards in front of me. I really want to fight this thing. And they say, I'm ready to do it. They sit down and they get their meal and they say, that's way too much. I don't need this much. Why did the dietitian give this to me? She doesn't know what she's talking about. I'm not going to have that. So you just went in from determination back into pre-contemplation. Okay? And then by later in the afternoon, they might be in action stage. So it is a very fluid process, but it's something that clinicians can do. We can look at it and say, okay, this sounds like this is where we are. Or we could ask them, where do you think you are in the stage? And what do you think it would take for you to move somewhere else? If you're in contemplation, what would it take, or what would you need to help move you into determination? And this can start to blossom some of that back and forth and that therapeutic relationship and form some of the trust. So I'm going to talk a little bit about treatment teams as well. Of course, eating disorders we know are very complex, not only physically, emotionally, psychologically, spiritually, that we need a diverse team that kind of has specialties in each of the areas so we can challenge all those different parts of the eating disorder at one time. So treatment teams are usually consider of a doctor, a therapist or clinician, a psychiatrist, a dietitian, the adolescent's still in school, it's important to have a teacher or a school liaison as part of the treatment process, an activities coordinator or group specialist, somebody that can really help the adolescent start to form movement or doing physical activities in a healthy way and explore that. That's an important part of adolescent recovery. Also, I feel that families need to be included in this process. I know in some instances when adolescents come into residential or inpatient treatment, it's typically not always close to where the family is actually from, so they're far away, but they need to be included by phone. Or one of the things that Rosewood does, I know, is have an intense family week program where people can come in for that week-long process with the adolescent. I know other places have that as well. I think that's a really important component, is to be able to include families in the treatment and also educate them on healthy communication, educate them on healthy ways of presenting with that adolescent, because when adolescents come back home, they're ultimately, in most cases, going to be going back home to the primary caregivers, and it's important for that environment to be worked on. Also, for any clinicians that are listening to this that work in facilities that help facilitate discharge planning, when they do go home, I think it's paramount that we include family therapy. The family therapy work should continue just as the individual work continues when an adolescent leaves, say, an inpatient or residential facility. They need to be included in that process the entire way, because it really is, when it comes down to it, a family disease, not just about the individual. So if there are any other questions, I will turn it over to Libby and see if I can answer some of those for you all, and I appreciate your time.
Great, Lee. Wow, very informative. And we have quite a few questions, and I don't think we'll get to all of them, you guys, but please do write me if we didn't answer your question, and I'm more than happy to send a response from Lee for you. But I'll get to as many as I can. One of them comes from a therapist who says she's just new to working with adolescents with eating disorders and doesn't have a lot of experience, has some experience referring to an inpatient setting. And she wants to know a little bit about what you might see and hear in an adolescent in their first week or so as they transition into treatment.
Yeah, absolutely. Thank you for the question. One of the things that I think is really important to remember, and this goes back to the last slide of why it's important to keep families involved through this process, is usually when an adolescent is going into a residential, inpatient, or other 24-hour-a-day care facility, it's because they couldn't contain the behaviors in a less structured environment. So we have to think, when they first come in, they're going to have individuals that are going to be assessing them, nurses, doctors, psychiatrists, therapists, and we're really going to be challenging that eating disorder. So if we got to think, if this eating disorder has been solidified in the adolescent and they've used it to feel worthwhile, or they've used it to feel important or accepted, they're coming to a place where we're going to ask them or examine the possibility of giving that up. And that's going to create a lot of anxiety. And when there's a lot of anxiety, I think there's going to be a lot of resistance, so there's going to be a lot of phone calls home that are going to be, pick me up, I don't need to be here, it's not that bad, I promise I won't do this anymore, I don't need this level of care, the other people here are worse than me. And really what we tend to see is that's an attempt to control the situation and not have to start to face some of the scarier parts of the therapeutic process, which is letting go of some of these behaviors. So it's not uncommon, sorry, long story to answer your question, but it's not uncommon to see the most amount of resistance happen right when the client's coming in.
That makes sense. Thank you, Lee. The next question that I see on the board is, what's an example or a few examples of how you use motivational interviewing in the treatment process?
Yeah, thank you. Again, another good question. And I'll try to give you a more consolidated example of this. Is you can ask adolescents, either it's a group check-in or it can be an individual check-in. You can examine. They can talk to you about what behaviors they're working on. You know, they can say, I'm trying not to binge anymore. You can say, well, how important is not binging to you on a 0 to 10 scale? And they might say, well, it's an 8. And then you can ask them, okay, well, why isn't it a 7? Okay, so it's an 8 because it's important to you, because you want to get back into sports, you want to see your family, you want to be home, you don't want to be in a treatment facility. Okay, great. Is there anything you think we can do to make it a 9? And then after examining how important they identify changing a certain behavior is, you can look at how confident they are in changing that behavior. So if they say it's an 8 that I don't want to binge anymore, and you can ask, okay, well, how confident are you in being able to change that behavior? And then they might say, well, I'm a 3. Okay, and we need to respect where they're at and say, well, if it's a 3, why is it not a 1? And they might say, well, because I've been able to follow my meal plan, and I haven't binged in a week, and I've been using the group. So they're starting to feel more confident. And then the important question to ask then is, what can we do together collectively to increase your confidence so you feel more confident about doing it? And they might say, well, I need to do more affirmations, or I think maybe I could try doing affirmations in the mirror, or putting sticky notes on the mirror about all the things that are important to me and why I'm valuable and important as a person. And then you can just recheck in with it, and you can add assignments, and you can add challenges. But it's important to include them and really find out where their confidence level is, how to increase it, and then monitor any change behaviors you see.
Yes, wonderful tool set there in motivational interviewing, Lee. And that does take us to the end of our time. And Lee, I'd like to thank you for coming in and sharing some of your experience with adolescents. And for everybody else, thank you so much for joining us. And I look forward to seeing any of your questions or requests for slides. And please do visit us next month for our clinical lecture series with the Rosewood Institute. Thanks. Have a great day.